It is my pleasure to welcome our last speaker, Dr. Matthew Goetz from the Mayo Clinic. Dr. Goetz is professor of oncology and pharmacology at Mayo Clinic. He's the Erwin K. Hobb Family Professor in Cancer Research and director of the Mayo Breast Cancer Spore. Dr. Goetz is the Deputy Director of Translational Research for the Mayo Comprehensive Cancer Center and is the Research Chair for Department of Oncology. He will update us on adjuvant therapy for hormone-positive breast cancer, which agents, when, and for how long.
Well, good afternoon, and I am the last speaker. I noticed that there's a few people that are still here, so hopefully we'll make it worth your while. I have no comments about football teams because I come from Minnesota, and invariably we do not have good football teams, so we don't have to worry about that. Okay, I've been asked to talk about adjuvant endocrine therapy, and I want you to have one takeaway. Give endocrine therapy. It's like drink Diet Coke or drink Coke, so give endocrine therapy. That's my takeaway. In all seriousness, I'm going to show you some data as to why we think that this is important. So this is the outline. We're going to review the incidence and natural history of ER-alpha positive breast cancer, describe or define the impact of adjuvant hormonal therapies, discuss some of the newly approved drug strategies to address primary hormonal therapy resistance, and then we'll have a brief discussion regarding extended adjuvant hormonal therapy. And there will be a manuscript that will be coming out fairly soon on this that I think will be quite important. So these are the most recent data with regard to age and subtype incidence of breast cancer. On the right, you see the US trends and incidence from 1975 to 2020 for all cancers. This is why when you do your boards, they have so many questions about breast cancer. If you ever wondered why, because it's a very common cancer. Globally, 2.3 million women estimated to develop breast cancer. In US, the numbers continue to go up. And interestingly, the incidence of ER-negative breast cancer is going down. This has now been observed over a couple of years. And the incidence of ER-positive is going up. So the genetics are not changing, but the environment is clearly changing. So this was just published this last year, and I want you to, if there's a couple takeaways here, but people are referring to the increasing incidence of ER-positive breast cancer in premenopausal women as an emerging epidemic. So we've known about this very slow increase for some time. But you can see that in the last, really starting in 2016 and 17, we've seen this steep upward trends. Well, we're not doing more screening in these patients. That screening hasn't changed. So what's happening? It's unclear exactly what are the reasons for all this, although we have had a number of lectures that have reference to some of this, including, obviously, rates of obesity and BMI. That's kind of the bad news. Here's the really good news. The good news is, despite all that, we are continue to seeing drops in mortality, and that's because, obviously our therapies are continuing to get better. We're doing a better job of screening. So overall, we are actually really, if you look at down here from 1989 to 2015, the death rates decreased by 39%, and a huge number of breast cancer deaths have been averted. So here's a summary. I didn't talk about this, but this is still important. Most breast cancers express ER-alpha. The incidence of ER-positive breast cancer is slowly rising overall, but it's this really steep trend, and we're going to have to watch this very carefully, but we're concerned about this in premenopausal breast cancer, this increase. And the good news, of course, is we continue to see these substantial gains. So this is what we do in the clinic when we treat ER-positive breast cancer. You know about this. There's nothing really new here. We either target the estrogen receptor through SERMs. We can degrade the estrogen receptor. Those are the FDA-approved drugs, although there's many that are coming that are also degrading the estrogen receptor. We can decrease estrogen synthesis. So these are our tools that we have, and those tools actually work very good. I always show this because, it's an old slide. I was taught this years ago. And I still today am quite interested at the fact that you take the drug for 5 years and the curves don't come back together. This is called the carryover effect. So you take the drug for 5 years, the curves continue to separate. And of course, aromatase inhibitor is even better than tamoxifen. So today, we say that compared to control, an aromatase inhibitor reduces the risk for recurrence and or death by about 70%. It's a huge benefit. Well, those are old data. We don't believe those anymore because we're in the modern era. So let's actually look at the National Cancer Database and find out what happens in real life. What happens in real life is some people don't take endocrine therapy. And so what we did is we simply looked at, in a very high-risk group of patients who had neoadjuvant chemotherapy, because the doctors said, Lise, your risk is very high. We simply asked the question of what happens if you omit endocrine therapy. And it's sobering. So you can see in ER-positive, HER2-negative breast cancer, about a 1.7-fold higher risk of death at 8 years. In ER-positive, HER2-positive breast cancer, a 1.6-fold. You saw the data from Patina. Just because it's HER2 positive and you have a fancy drug does not mean you should ignore the estrogen receptor. These two are linked, and they do crosstalk between each other. So targeting the estrogen receptor is very, very important. Well, what about ER-low breast cancer? Well, this was really something that I was quite interested in because we don't know a lot about ER-low breast cancer. We know that adjuvant endocrine therapy reduces breast cancer recurrence. Adjuvant endocrine therapy omission is bad. But what about this 1 to 10%? Because biologically, this is considered really very similar to triple-negative breast cancer. When I see a patient with 1 to 10%, I don't embark upon primary endocrine therapy as my strategy. I say, listen, we're going to treat this patient with chemotherapy. So what about this 1 to 10%? The NCCN guidelines are not really sure about what we should do. That's sort of some equipoise. So we looked at this in the same data set. These data are in PRESS and JCO. And what we did is we looked at the NCDB for these data. Now it's interesting because in the NCDB, just in the last 5 or 6 years is when they started actually giving discrete information about the ER. So it used to be just positive or negative, so we weren't really quite sure. So what we did is we looked at this group of patients that were ER 1 to 10%, and I just wanted to show you, so over from 2018 to 2023, it's a pretty large group of patients with stage 1 to 3 ER-positive breast cancer, 354,000. Again, this is a common illness, a disease, excuse me, in the United States. So 10,000, so 3% are a relatively small number, are ER low. And again, you can see these people are being appropriately treated with chemotherapy, most of them with neoadjuvant chemotherapy. The bottom line is that we looked at whether or not patients did or did not take endocrine therapy, and about 40 to 45% of patients omitted endocrine therapy, and probably because physicians and patients don't know what to do. What we found was interesting is if you look at the right-hand side, what you see is that if you have a path CR, and you look at the hard input of overall survival, these patients do extremely well, and you can see there's really no impact at endocrine therapy omission. In the middle is the curves actually where patients are getting therapy blindly. We don't know how they're responding to chemotherapy. We just give chemotherapy afterwards. And you can see in those patients, maybe there's a slight difference. But in those patients that had residual disease, now you see this difference. And actually you see an absolute 7% decrement in overall survival. So what's actually going on? Well, you can see that, I just mentioned these data, if you have residual disease, this is where you begin to see the difference. We also looked at just the amount of ER, 1 to 5% versus 6 to 10%. So the more ER was also associated with a detrimental effect. I don't show these data, but we just looked at our own data set at Mayo Clinic, about 1,000 patients. And the question is, how many of you recheck the estrogen receptor in your residual disease after neoadjuvant chemotherapy? Please do, because it was enlightening when we did it. We just submitted it for an abstract. The reality is most of these patients stay ER negative, but when you have a big tumor, especially a large tumor, you have tumor heterogeneity. That's the bottom line. And when you put that needle in one part versus the other part, you're going to miss some ER-positive disease. So now you've gone through 20 weeks of neoadjuvant chemotherapy, you have residual disease. How do you know what's remaining was actually not an ER-positive clone? So that's where we think it's probably making a difference. And this is a hypothesis for sure because we haven't verified this. There are no prospective clinical trials. But the suggestion is recheck endocrine therapy because we have options we can give these patients. These drugs are cheap, and we also have the option of giving a CDK4/6 inhibitor. This is a secondary analysis that we did. We haven't published this as of yet, but we presented this at ESMO a few years ago. This is a step analysis of IDFS benefit across ER expression in Monarch E. And the bottom line you can see on the very right-hand side, we're really clustered with these very high expressing disease. In blue, you're seeing the hazard ratio, and then the dotted lines are the confidence intervals. And so the confidence intervals are fairly wide, especially as you go to the lower levels of ER. But the suggestion here is that there may be a benefit of abemaciclib even in the ER low breast cancer patients. So my summary here is, we spent 5 decades of work focusing on understanding the biology of ER alpha breast cancer. There's substantial benefits on recurrence and survival. Patients with ER-positive treated with neoadjuvant chemotherapy and have residual disease, there's a large detrimental impact on overall survival if you don't give endocrine therapy. I always tell patients, I said, you just went through 20 weeks of, where you threw up, you were sick, you were tired, you lost your hair, and now the hard part begins. You have to remember to take this pill every day. And that doesn't seem right. Well, the hardest part actually has to get through the chemotherapy, but if you have a very high expressing ER-positive tumor, that's actually critical. So, and I also suggest consider retesting ER alpha expression with patients with ER low or ER absent disease who have residual disease. The ER absent disease is still a question mark, but again, especially for some of those larger tumors where there may be tumor heterogeneity. Okay, skipping on to primary endocrine therapy resistance. This is a story that most of you know really well. What we do in the clinic is we try to figure out who we should escalate, who we should de-escalate. We've heard about adjuvant chemotherapy, critically important for tumors that are endocrine unresponsive. Adjuvant PARP if you have a BRCA mutation, adjuvant CDK4/6 inhibitor. So we have these ways now to escalate our therapy. And so this is just a slide that I always find is really interesting. This was published in JCO a couple years ago in the midst of COVID. But what you can see is that when you look at the recurrence score, the proliferation module is actually fairly, the Spearman's coefficient of correlation here is not that great, 0.36. What you see is that the ER module is highly correlated with the recurrence score. So in patients that go from 0 to 20, you see that difference there. And so the suggestion is, of course, as you get into the high-risk patients, you really tend to have lower ER. And that's probably why the patients benefit from chemotherapy. Just to remember for Taylor RX, recurrence score outcomes of 11 to 25, no benefit of chemotherapy. And in RX Ponder, same thing. The interesting thing in the premenopausal was that there was this small benefit of chemotherapy in patients treated with, who had a recurrence score of 0 to 13 or 14 to 25. And so our conclusions is in postmenopausal women right now, it's fairly clear we shouldn't be giving chemotherapy if you have 1 to 3 positive lymph nodes and you have this intermediate recurrence score or node negative. But there is a small chemotherapy benefit in premenopausal women. Actually, it's seen in Taylor X, it's seen in RX Ponder, it's seen in MINDACT. And so there's 2 hypotheses. If you're an endocrine guy, it's all about endocrine therapy. If you're a chemotherapy guy, it's all about chemotherapy. The reality, it's probably something in between. So the endocrine hypothesis just basically says in those studies they gave tamoxifen monotherapy, we know that's inadequate. And so maybe that if we just give adequate endocrine therapy, it'll actually be, I can't go back, but forget that. We're going to forget about the cytotoxic chemotherapy hypothesis because that's not important. Just joking. But anyway, this has now led to is the BR009. This is a really important study in premenopausal women where we think that there's equipoise. Patients are being randomized to either ovarian function suppression and an AI, so proper adjuvant endocrine therapy versus chemotherapy plus OFS and an AI. So I think this is a really important study that hopefully will be able to answer this question. Let's move on into the adjuvant setting, the adjuvant CDK4/6 inhibitor trials. So we've had a number of them, Penelope B, Pallas, Monarchy, and Natalie. I won't go through the first two trials. Those were negative trials, but very, very important trials. Monarchy and Natalie are the ones that have demonstrated a benefit. Here's the Monarchy study where the eligibility was very, very high-risk patients, so greater than 4 lymph nodes or 1 to 3 with high-risk features. And we've had some recent updates. This is just in the last year. We're seeing a sustained benefit in IDFS, which is good, because remember, you only take the drug for 2 years. So even though we've only taken the drug for 2 years, we continue to see benefit. Some people would like to call this carryover. It actually might be. Certainly, the good news is it's sustained. We see it in terms of distant relapse-free survival. We don't see an overall survival benefit as of yet. And some people would say it's probably just because we don't have enough follow-up, and this is because this is one supporting hypothesis. If you look at the additional interim analysis here, you can see that, for example, in the OS interim analysis 3, in patients that received endocrine therapy alone, there's a lot more patients, almost double, that are being alive and living with metastatic disease. So that's important, because what we're doing obviously here is we want to improve survival. I think it's too early to know, but you can see that we're having an impact on the survival of patients with, we're having an impact on being alive or not with metastatic disease. This is just an old slide, which is a reminder that Ki-67 is prognostic. We don't use Ki-67 alone to make a decision about therapy. There was some confusion initially, but I think we've weathered that storm. This is just a secondary analysis of utilizing data from Monarchy, just showing that the 21 gene recurrence risk score, this is an inferred, so this is using RNA sequencing and inferring the 21 gene score. It didn't seem to be that in patients with low or high oncotype score that there seemed to be a differential benefit. And then this is just another presentation. This is from ASCO. We're beginning to get some data now with the use of ctDNA from patients who entered into some of these clinical trials. What you can see is that if you got through, most of these patients on Monarchy were treated with chemotherapy, and so if you got through all that treatment, chemotherapy, and you're now registered onto this trial and you have baseline ctDNA, really is associated with a very poor prognosis. The question is still, what do we do with that? It does look like there are some dynamics, so it looks like some of the patients that are positive are improved, or we see clearance of the ctDNA, and so it looks as if those patients do better. Those patients that were negative at baseline and become positive. So we're all sorting this out, I think, from a research standpoint. We're not yet using this routinely in our patients. Sometimes patients ask me, well, why shouldn't I give it to you? Why shouldn't we do this? And I say, you know what? We've just given you the kitchen sink. What else am I going to give you? So if I monitor the ctDNA, what we want to do is be able to say, listen, if I find a positive result, I'm going to be able to do something about it and then improve the overall outcome. Now, the reality is in the future we'll have better drugs and we'll be able to improve the outcomes. But we're still sorting through this. Natalie, a very important study, also demonstrating improvement. The big difference with Natalie is they did allow high genomic risk node-negative patients. We've seen the data with the final IDFS. We're seeing something very similar to the Monarchy study. Remember, with this drug, you have to take it for 3 years, or that's how they took it in the clinical trial. Distant disease-free survival, we're seeing something similar. And then here's some data with IDFS by nodal status. I think we'll need to see longer follow-up here. Right now, we are seeing a difference. The difference, the delta, of course, is relatively small, but again, we will await longer follow-up. But again, now what we can say is we clearly have two options that we can use in the adjuvant setting to escalate therapy for these high-risk patients. I'm going to just end by just briefly going through this. I'm not spending a lot of time on this for the sake of time. You've all seen these data. These are the 20-year risks of breast cancer recurrence after stopping endocrine therapy at 5 years. And so we've had this question now for some time about the role of extending adjuvant endocrine therapy. And so the Early Breast Cancer Trials Collaborative Group first presented these data, about 5 or 6 years ago. The statistician that was actually on the podium that presented these data actually passed away, Dr. Richard Gray, and he passed away this last year. The data have had additional follow-up, they've added additional trials, and now those data actually will be published very shortly. But I just want to show you probably what's the most important part of the publication that will be coming out, and that is the data with regard to 5 years of an AI after 5 years of an AI. So this is what we face, obviously, the most commonly in the clinic. We don't treat, well, we hardly treat any postmenopausal patients with tamoxifen anymore, at least the high-risk patients. So what you can see here with regard to A, B, C, and D, A is recurrence, B is distant recurrence, C is contralateral recurrence, and then D is breast cancer mortality. So what you see is these drugs clearly do work. They work in terms of reducing the risk, about a 25% reduction in the risk for recurrence. They also reduce distant recurrence. We know that they have a benefit on the contralateral breast in terms of recurrence, but as of yet, we don't see a difference in mortality. Now, it could simply be that we just don't have long enough follow-up, and that may be the reason for the lack of a difference in breast cancer mortality. But I wanted to show you these data here because this is probably the thing that we face most commonly in the clinic, which is I have a patient, she had node-positive disease, and I want to think about using an adjuvant, or I want to think about using an extended AI. So bottom line, what you see here is that the relative risk reduction is almost the same, and you would expect that. So relative risk reduction, 0.72 versus 0.76. So just because you have more disease, the benefit of the relative benefit is the same, but of course the absolute benefit is going to be larger. So on the right-hand side, you can indeed see that patients that had node-positive disease, there's about a 4% difference there in terms of the recurrence risk. So, you know, this is now the data that we have, and as we think about our strategies to reduce late recurrence, obviously we can take tamoxifen for 10 years. We don't do a lot of that, but occasionally in a premenopausal patient, we may do that. Tamoxifen for 5 years followed by an AI. Again, this is still a possibility, especially for those women who were premenopausal and then became postmenopausal, and then AI therapy for 10 years. But I think what it's very important to show you is that this benefit is pretty modest at best. This is not a home run for extending, for improving recurrence. Nevertheless, it's a tool that we have. I'm not going to spend time today talking about the strategies. People have talked about this before. There are a number of strategies to to better individualize adjuvant therapy. We could use the CTS5, which is another way to identify risk. Molecular markers such as BCI, we've seen data with MammaPrint. And I think the real exciting area right now is these studies that are ongoing to look at minimal residual disease, where you take the higher risk patients and you begin to, to get the DNA footprint of that primary tumor, and then look for ctDNA in the circulation as a way to identify at higher risk. So These strategies, I think, are going to be employed in the future for doing extended adjuvant therapy. In the meantime, this is what we have. We do have a tool that's available to extend therapy, and it does reduce the risk for recurrence. It reduces the risk for distant recurrence, and I think it's definitely applicable for higher risk patients. So, the takeaways: give endocrine therapy, and I'll leave it at that. Thank you.